Thank you, Dr. Bello, for that, for the great opportunity that you've given to me. I want to thank the last presenter. He has really done justice to pharmaceutical care in COVID-19 patients. There really is not much I'm going to add, but I'm only going to talk about national security and safety as regard pharmaceutical care in Nigeria, taking Nigeria in perspective. We've been trying to reach pharmacists that are really at the front line, pharmacists that are in the isolation centers in Nigerian COVID-19 isolation center, treatment centers. I've tried to get across to some, but I've not. But I've gotten across to some doctors. And there is a protocol for actually working in the isolation center. They work as a team. They go in to offer treatment and therapy, and they come out as a team. And I believe that the pharmacist should be a vital member of that team. And that is where pharmaceutical care comes in. You see, COVID-19 is a novel disease. Novel in the sense that nobody has heard about it. That's why we cannot get a vaccine immediately. But I believe that novelty, that novelness is an opportunity for pharmacists all over the world, most especially in Nigeria, to restructure their healthcare system. Yes. How do I say we should restructure our healthcare system? What I mean is that now that COVID-19 is here, I see pharmacists interfacing in 3 areas. You talk about the risk communication and social mobilization. You can call it advocacy. You can talk about the community practice and the inpatient management of COVID-19. Hello?
Yes, we hear you.
Those are the 3 vital areas for which pharmacists should be actively involved. He has talked a lot about the infection, the pharmacotherapy, and all of the rest. On 2 or 3 occasions, a doctor that is working within the isolation center actually called me and said that they have an elderly patient and they want to administer chloroquine. I asked for the blood pressure. He says it's an hypertensive patient, maybe having having congestive heart failure that may be a secondary to the hypertension. I now remembered that if you look at hydroxychloroquine and chloroquine, they tend to, elongate or prolongate the QT segments of the electrocardiogram, and that tendency can actually aggravate cardiovascular functions. So I actually told him, no, you cannot give. But he said the person is on ventilator and is not responding. And I remembered there was a study I actually read where, I don't know whether we actually read that study, where there was this thing on social media that once they put a COVID-19 patient on ventilators, they tend to suffer more mortality. What was the reason? The reason was that lots of these patients that actually require ventilators, most of them have already a compromised cardiovascular architecture. And now you are now giving high volume of oxygen using high pressure. Of course, it will deteriorate the cardiovascular function. So the new order of therapy for that now is actually to give at low pressure but high volume, so that you will be able to maintain the cardiovascular architectures. These are some of the things that are needed in the inpatient. Luckily for me, I've actually been working with international NGO where we do short and long-term medical missions. And I had the opportunity to actually bring pharmacists on board to participate in the mission. And what I actually do was that when we normally have our normal hospital outreaches, I engage pharmacists to be in the ward, to follow up patients post-operatively, see how they are managed, and add value to the system. What was I trying to do? What I was trying to do is that we need to be at the bedside. We need to be at the bedside of COVID-19 patients. Very well, we can carry out the advocacy. Yes, we can do that. But let me tell you, somebody else can actually do that too. Yes, community practice is an exclusive area. Nobody can compete with that. But there's something vitally absent at clinical care, the input of pharmaceutical care. If you look at the steps of pharmaceutical care, first, you establish a professional relationship. Be it at the community pharmacy, especially during this period of COVID-19, you need to establish professional relationship with your patient. I don't know whether there is a pharmacist in the inpatient, all geared up, gowned up, following the team. He too needs to establish a professional relationship with that patient, because you know there is nobody wants to have COVID-19. Everybody is afraid. A suspected asymptomatic patient may come to your community practice. You need to establish a professional relationship. Before you do that, we talk about even the personal protective equipment. There are protocols for actually, wearing those things, how to wear your face mask, how to do your hand washing, how to dispose of waste. There are protocols which pharmacists have to be, knowledgeable about. The last speaker said something about being knowledgeable about that. Yes, so that you'll be able to fit in. Lots of these people that went, taking care of COVID-19 patients, they actually were trained. Pharmacists needs to get involved in that. Yes, because vitally, most importantly, scientific provision of drug information can only be provided by a pharmacist at the bedside. Why am I saying at the bedside? At the bedside is that the protocol that is actually associated, with inpatient management of COVID-19, most especially in Nigeria, you go in as a team, and the team, they live in a particular place. Why? Because to reduce the risk of contamination. Everybody goes, attend to a patient, deliver the therapy, whether scientific drug information, medication reconciliation, changing of diagnosis, nursing care. It is all done at a time, and they all leave. And when they are changing up, they leave. So there is that movement of trying to say a pharmacist should be at the pharmacy outlet, away from the bedside of the patient. Of course, when you look at the distance, walking down, coming back, you will find out that the risk of contamination is very high. So I don't know how it's obtainable in the US, because definitely when you start moving things in and out, and personnels, they begin to move in and out. You need some consumable from the pharmacy, you bring it in and out. Normally, the trolley moves along with the team. So should the pharmacist move along with the team. Very vital. Provision of scientific drug information, very, very vital. And it can be life-saving. As I told you, as I intervened with, through a doctor friend who was in the team and managed that patient. Very, very vital. Yes, we cannot take away our role down there. Yes, definitely. I've talked about security. You see, the impact of COVID-19 has actually affected the national health system. Because when you look at these patients that are being discharged, some of them go back with home drugs. I believe that those patients should be referred for continuous management to the community pharmacists because they are closer to them. The fear of going back to the hospital is not always there. They always see the pharmacy as a very friendly place to go. So it's very vital we look at that issue, scientific provision of information. He talked about different type of drugs that are being undergoing trial. Definitely. Remdesivir is one of those beautiful drugs. It blocks the viral replication. It acts as an analog. Instead of the virus taking in the protease, it takes in that and it kills the virus. But the research at that level is still at a very small scale level, because you cannot take the report or the result of those trials and take it to a larger scale, because you need to extrapolate it and do it in a larger population to take into consideration a lot of founding factors. Hydroxychloroquine disrupts the endothelium and doesn't allow it to form and enter into the cells. That is another very beautiful drug. And another good thing about that drug, which of course we can actually provide at the bedside to other healthcare providers, is that they are very diabetic friendly. Yes. They are also very friendly with people that have chronic kidney diseases. Research has actually shown that. All right. So research has actually shown that. So we need to be proactive. Yes. Very, very proactive. We need to get ourselves to the bedside. There is lots of knowledge that is there within us, but we are not at the side of the patient, which is one very vital reasons why, a lot of people are talking, when you want to mention patient management, you tend to want to forget about the pharmacist. We should not be so. We should not be so. Definitely. So we should look at COVID-19 management in all the three, especially at the community practice and inpatient management of COVID-19 patients, using the 6 steps of pharmaceutical care. You establish a professional relationship. You obtain specific objective and subjective information. It's very vital in case, especially in the community pharmacy, you may want to begin contact tracing of a patient that has come to you. When you begin to get those subjective and objective information, is very vital. You go to drug therapy problem identification, which is step 3. Step 4, you go to pharmaceutical care implementation and intervention, which is very vital. You now look at the number 5, which is drug evaluation and monitoring, continuous monitoring. Very important, because you may have a patient in the community pharmacy that has come to you. Yes, decides to come to you, never is an asymptomatic patient. All of a sudden, you know that it develops the symptoms. You will be able to connect with it because you already have a monitoring mechanism in place. Very vital. We should document all our activities. Document most especially for research purposes. As I said in one of my write-ups, we will not be able to get the number of patients that have suffered adverse drug reaction because of the cocktail of drugs that are involved in the supportive care of COVID-19 patients. We need to know patients that we are giving overdose that, maybe mortality rate that was as a result of overdose, misuse of drug, the kind of drug interactions that are involved, because there is a lot of drugs that are being used, not on standard protocols or guidelines, but experimented. We need to have those information, and that will actually guide to prepare our protocols, most especially in Nigeria. Thank you very much.